Hello, and welcome to the workshop, CAR T-Cell Therapy for Multiple Myeloma. Who's a good candidate? My name is Michelle Kosick, and I will be your moderator for this work group. My pleasure to introduce today's speaker, Dr. Tara Gregory. Dr. Tara Gregory is a physician at the Colorado Blood Cancer Institute, where she is a part of the plasma cell disease group. Her research focuses on treatments for patients with multiple myeloma, including CAR T-cell therapy. She also participates in clinical trials to improve outcomes after bone marrow and stem cell transplants. Please join me in welcoming Dr. Tara Gregory.
Thank you, Michelle, for that introduction, and thank you so much for joining us today. As Michelle said, my name is Tara Gregory, and I am one of the physicians at the Colorado Blood Cancer Institute. We specialize treating patients in the Rocky Mountain region with blood cancers and additionally what we call cellular therapeutics, which can include bone marrow transplants or stem cell transplants, as we call them now, and modifying people's immune systems, which is getting very, very exciting, and we'll be addressing that today. So first, we'll start with some disclosures. I have participated in advisory boards for both Johnson & Johnson and Legend. And today what we're going to talk about is a lot of myeloma focus and why would we want a CAR T-cell therapy in myeloma treatment. What exactly is CAR T therapy? What are the steps that it takes to undergo CAR T-cell therapy? And I see already we're going to have a lot of really great questions about what that involves in day-to-day life and work. The potential outcomes after CAR T-cell therapy, is it potentially a cure for myeloma? And then the flip side of that is, what are some of the short and potential long-term risks that can be associated with CAR T-cell therapy? We'll talk about the impacts on quality of life, and then ultimately, who is a good candidate. So we'll go ahead and get started. Now, first, what I want to do is talk to you guys a little bit about multiple myeloma and make sure that we're all on the same playing field. I know that I have some of my patients out there, so in the audience, so I know that they're used to this. But in my world, I think of the immune system like a big military operation for your body, and its job is like homeland security. We're trying to keep foreign invaders out. And when they infiltrate us, like infections or something like that, their job is to fight that off. And the additional thing about the immune system, which is important to know, is that the immune system is also surveilling our bodies all the time for any cancer cells and any cells that might look weird or acting funny, and their job is to clear those guys out too. So that's a very important part of our immune system that we don't think about. And when I think about myeloma in the grand scheme of things, I think about where myeloma started. And multiple myeloma starts from a type of white blood cell called a plasma cell. And the job of the plasma cell in the immune system, I think, is Lockheed Martin or Raytheon. And as I understand it, Raytheon's not called Raytheon anymore, so I'm going to have to figure out what it's called now. But the job of the plasma cell is to make immune proteins or antibodies that are heat-seeking missiles for specific infections. So typically what you want are a lot of different kinds of plasma cells because they're all going to make their own special antibody that's going to fight off its own unique infection. And what happens in multiple myeloma, and it's always a tricky one, as you guys know, because instead of calling it lung cancer or breast cancer, we call it multiple myeloma, not plasma cell cancer. We say, okay, well, we have too many of the same plasma cell over and over and over, and that's called being a clone, a lot of one of the same things. And or monoclonal is the other word that we make for that. And then what happens is that you make the same antibody over and over and over, and instead of being an amazing heat-seeking missile, it's a dud. So it doesn't work, it doesn't fight infection, it doesn't go ahead and grab onto those bacteria and drag them over to the immune system and say, hey, look what we found, should we eat this? And so we get way too much of this abnormal protein, and sometimes the buildup of that protein can hurt us. So that's where I start with talking about the immune system as a military operation. We got a Lockheed Martin Raytheon problem. So moving along, if you're in any myeloma talk, this is a pretty standard slide that we like to show. And what this is showing in the first box, it'll say asymptomatic and MGUS or smoldering myeloma. Everyone who has multiple myeloma had pre-myeloma first, and oftentimes we just didn't know it. Or sometimes we were able to pick up on it just from some routine testing, and somebody decided to order some specialized testing and see this was going on. And so one area in multiple myeloma treatment is trying to say, how can we identify those patients with pre-myeloma? Should we say, well, your pre-myeloma is not that bad, so let's not really worry about it, and we don't really ever need to check it again? Or your pre-myeloma is actually pretty aggressive, and maybe we should treat you. So that's an area that's really changing. And eventually, what we can do is we can predict for those patients who have that MGUS or smoldering myeloma when we think it's going to start to cause problems. So in about 2014, we said, we used to wait before 2014. We said, if you have a myeloma problem, we're not going to treat you. We're just going to keep an eye on you and wait for you to have a problem. And then we said, well, that's probably not a great idea. People shouldn't be breaking hips and having kidney problems and being exhausted because the red blood cells get so low. So we should go ahead and treat them. And so now we have some criteria that say, well, if you have enough myeloma, let's go ahead and treat you because we think something, not great is going to happen within the next year or two. And so we do the initial treatment. So this graph is supposed to kind of represent the myeloma, and we drag it back down. And then we get some time before the myeloma creeps back and does what we call a relapse. And then it perks back up, and hopefully we find that relapse by the numbers before it hurts anybody again. And sometimes we say, maybe the numbers aren't that bad, but we don't like the changes in the organ function, and we're headed, a not good way, we want to change. And then we treat it again, and it goes back down. And then it goes back up, and we treat it again, and it goes back down. But what happens is that over time, how far down you can get the myeloma to go and how long it can stay under control, all those things shorten, and the responses don't get as deep, and the amount of time that you get with a response gets shorter. And ultimately, we see myeloma start to get out of control, and then it behaves less like Lockheed Martin or Raytheon, and then it just starts acting super weird. So that's typically what we see when we're looking at myeloma therapy. And as we look at the years and what's gone on in the treatment of myeloma patients, if you look at this back in the 1940s, we started giving people chemotherapy. In the 1960s, we said, okay, well, let's give combinations of good old-fashioned chemotherapy. In the 1980s, we came up with this thing called a stem cell transplant where we say, well, if a little chemo is good, more is better. Let's wallop you with that. The problem is it's really good for killing myeloma cells and getting them down to super low levels, but it's really good at killing your bone marrow. And your bone marrow makes all those special cells that float in your bloodstream, and keep you from getting sick or, that keep you from bleeding and carry oxygen around and fight off infections. And so we have to reseed your garden in a sense where we collect your own blood maker stem cells first, give you the big chemo, and put your stem cells back in again so that they can regrow things after we broke it. Then in the 90s, we said, well, and this is kind of what we do in myeloma. We say, we do this in cancer in general. When we come up with new stuff, we say, let's give it to people who have the worst of the worst, and let's try it out on those people first. And then we say, wow, this works really great. Maybe we should be moving this up further and give it to people sooner because the people with bad disease did so great with it. Maybe that should be coming, to the front of our treatment regimens. And so that's what we did in the 90s. We said, okay, well, transplants for people with really bad myeloma worked great in the 1980s. Maybe we should start with that. So then that's where really in the 1990s, so over 30 years ago, we said we should do transplants. In the 2000s, we started coming up with some new drugs, and those drugs are called immunomodulatory agents. So those are drugs like lenalidomide, pomalidomide, and they work a bunch of different ways to help fight off the myeloma. And one of the things that they do is they rev up the immune system so that the immune system can help see the cancer as foreign and fight it off. We came up with these drugs called proteasome inhibitors. Those are drugs that block what I call the protein pooper in the myeloma cell. If you think about the myeloma cells making all this protein, it's got to have a way to process stuff. and get it out. But if it gets blocked and it just fills up like a water balloon, eventually it's just going to pop. And so we've got those drugs, and those are like bortezomib and carfilzomib. So those were huge changes for us. So, it wasn't until the 2000s that we came up with these specialty drugs that weren't really like intensive chemotherapy. By the 2010s, we started to figure out that maybe we could use other immune proteins to see the cancer cell as foreign and lock onto it. And one of those are called an anti-CD38 antibody. And those are drugs like isatuximab and daratumumab. And what happens is they work a bunch of ways too, but one of the ways that they work is they grab onto the myeloma cell and it sends up a signal flare to the immune system, and it says, yo, over here, you missed this, come eat this cell. And so the antibody runs right over and says, or the immune system's like, oh, okay, I saw that signal flare. But, you're hoping you have an active immune system that's going to see the signal flare and recognize it and go over there and do something about it. And then we got into the 2020s, and that's where really myeloma treatment has just exploded in the last 5 years. So if we take a closer look, we said, okay, well, if the immune system is so important in fighting off cancer and recognizing cancer, and these immune attacks have been so helpful, starting in the 2010s through the late 2010s with these other drugs, where we're getting the immune system involved with the IMiDs and the anti-CD38 antibodies, what if we linked a different immune cell called a T lymphocyte into this situation? And so we've come up with two different ways to do that, which are what we call bispecific antibodies, which we'll get into, and then obviously CAR T cell therapies. So really that's only happened that we got FDA approval, in the last 3 years for these drugs, and we're already looking at new ways that we can apply treatment. So if you look at all this and you're like, well, this is a lot of really good stuff, and when I took care of patients, in the late 2000s, before 2010, I was like, oh, geez, like once your disease comes back, God, I don't know what I'm going to do for you. But now I say, God, when your disease comes back, what am I going to do for you? Because I've got all these options. So really, we're just trying to get people a lot more time so that we can get the next best thing out there for you. But there is still a huge need for new treatment. And so this is a study that's really important to us, and this was done in the United States, and it's called the Mammoth Study. So when you get a drug and a drug stops working, which means your myeloma gets worse when you're taking the drug, or your myeloma gets worse within 2 months of stopping the drug, we call that being refractory. And we really think of myeloma in that we've got three big important drug classes. We've got the IMiDs, which we talked about, the proteasome inhibitors, and the monoclonal antibodies. And so and then we have two different kind of proteasome inhibitors and two different kind of IMiDs. So then we say, okay, well, if you look at all five and those aren't working for you, or even if 3 or 4 of those aren't working for you and they stop working, then we're talking about the average patient not living very long. So we're using all these drugs, from the get-go. So we just really think it's important that we've got to be able to have things for people, because once these drugs stop working, then we need something newer and better. I think the other important thing about new treatment that this slide doesn't totally touch on is that when we start treating somebody with myeloma, we do our best to say, your myeloma should behave pretty good. We think it's going to, act like we expect it to. You should be able to get this many years off treatment. And there are other people where you say, I think this is going to be way more aggressive and we're going to have to be more aggressive. And then you get surprised. And there are people who don't respond that well, or their initial treatments and their transplants right off the bat don't last that long, like less than 2 years. And so we say, okay, this is a behavior that's very aggressive. And so we talk about these patients who have more of this, performance issue. And so we say those patients are considered functionally high risk. So that brings us into the immune system and CAR T. So one of the things that you guys need to know about me is that I am the only female physician in my practice. I don't know why. My partners are lovely, but I am one of 11 doctors right now. And so I really have to, like hone my female power. So when I think about the immune system and T cells to me are all female superheroes in my world. So that's how I think of a T cell. She's going to go in there and she's going to pound on stuff and fix it. And what these type of treatments are, what we call them, so we talked about proteasome inhibitors and we talked about IMiDs. This class of therapy is called immune effector cell therapy, or IECT. And there are really two big different types of IECT therapies. So one way that you can think of it is that your T cell is Wonder Woman, and we need to give her a lasso so that she can grab the bad guy, who's the cancer cell, and drag him in and pound on him. And so those are what bispecific antibodies do. They have two hooks, one that grabs Wonder Woman and one that grabs the cancer cell and drags them together. And then you've got your CAR T cell therapy, and for me that's Captain Marvel. So she got souped up and powered up. She was already in the military. She was doing really great. I think she was a fighter pilot, right? And then what happened is that she can really go in there and pound on the bad guys. So she doesn't need a rope to grab them. She just can go in there and bind directly. And so that's the difference between a bispecific antibody and a CAR T. One is a drug that you have to get all the time, and the other one is what we call a one-and-done treatment. So let's get into CAR T cells, since that's what we're talking about today. So CAR T stands for chimeric, and a chimera is something that has two different types of DNA. Antigen, which is a protein that lives on the myeloma surface. So if you look at this purple cell, this is supposed to be your myeloma cell, and you see that little half moon that's sticking out of it with BCMA next to it. That is called an antigen. Receptor, so then you have that yellow thing that's coming down from the green cell, and the green cell is our superhero, that's our T cell. And so that's a receptor T cell. And the goal is that they kind of snap together like a puzzle piece, the receptor and the antigen. And so what we do is, instead of collecting, stem cells from our patients, we collect T cells instead, and we'll get to that. And we change the DNA of the T cell so that it grows a new receptor that can bind onto the cancer cell. And what's important about this is we're using these IECT therapies for all different kinds of cancer. This is really the area where cancer care in general is exploding. And when you pick a receptor, or you want to pick something that's going to bind to the cancer cell specifically. You don't want it to go binding to your heart or your lungs or your skin or something else. You want it to be pretty unique to just the cancer cell. And at the same time, you want to make sure that pretty much everybody, like the majority of people with that cancer, make that protein. So you don't want it to be like, well, only, if I took 10 myeloma patients, only 2 patients make BCMA. So that's part of the trick, and why it can be really difficult for researchers to find, like, what's the right target. And so the one that we're using right now that's FDA approved in multiple myeloma is called B-cell maturation antigen, or BCMA. So that is our target. So going on to CAR T-cell therapy, we're going to talk in this slide. These two slides are a little repetitive, but one kind of talks about your journey and one talks about making the cells. So we'll talk about making the cells first. So first of all, when we decide that a patient needs CAR T-cell therapy, we bring you in and we put you back on that machine that collected your stem cells. And so it's called an apheresis machine. The lovely thing about T cells is that they do not need to be moved from your bone marrow to your blood. They live in your blood already. And when we collected your stem cells, we had to move the stem cells from your bones into your blood, and we did that with all those shots. So the lovely thing about collecting T cells is there's no extra shots. You just get hooked up to the machine, you run for 6 hours, we get the T cells, and then what happens is we have to ship them off to a company to make them into CAR Ts. So the first thing that they have to do when they get the cells is they have to say, well, this is a really good active Captain Marvel. Like, she looks like she's ready for it. Like, she can take the hit with the alien juice and survive it. So they activate these, or they find the activated T cells, and they grow those guys up. And then what they have to do is put new DNA into your T cell. And we do that with a particle that was re-engineered off an HIV virus. So it's not HIV anymore, but it's what we've learned when we've learned about that virus. that carries a new set of DNA that is going to make this T cell grow new little prongs. And so the new little prongs are, I don't know if it's easy for you guys to see, but those little like sea green or turquoise things that are sticking out of the blue cell. And then once you make those, then we say, okay, well, let's grow those up, and then they freeze them and they ship them back to us. So what it looks like for a patient is that you come in at step 1, you get apheresed. And so you typically have to do that at a center like my center where they can go ahead and collect these guys. Then, while the manufacturing is taking place, it is very important, specifically in myeloma patients, that we make sure that your myeloma doesn't get any worse. We know that when patients' myeloma is actively getting worse and not getting better, or you have a huge amount of myeloma, that it makes the CAR T cells way too active when they come back in, which we'll get into. So we want you to get some treatment. And I've even made patients get treatment for 4 months while I'm waiting before I'll let them have their CAR Ts back, because I just really want the myeloma under awesome control before I put the T cells back in. Once those T cells are ready, then you do have to get chemotherapy, because that chemotherapy that we give, one is called fludarabine. You could give it to me. I wouldn't lose my hair. I wouldn't vomit. I would get every single cold my kids bring home from high school, and they bring home a lot of stuff. And I would be sick, like really, really sick. So it does a really good job of knocking down your immune system. And then we also give you a drug called Cytoxan, and Cytoxan's pretty nauseating. So that's that's not fun. And both those drugs are given for 3 days in a row. And that's typically given, at least in our center, as an outpatient. It's a couple hours. And we do it for those 3 days, and then we don't give anything and we don't do anything for 2 days, because what that chemo is doing is it's dumbing down your immune system. Because I'm going to put these funky looking little T cells back in your body, and your normal immune system should see these and go, oh my God, like what is that? I'm going to go eat it. And we just spent all this time making these things, so we don't want your immune system to chew them up, so we do have to dumb you down first. And so we call that lympho, because we're dumbing down the other lymphocytes, depletion, we're decreasing them, chemotherapy, or LDC. After that, we bring you back in. We run the T cells in like a little blood transfusion, and they come back to you in this baby bag. They're only about 60 or 70 mLs. And if you think about like each one of your transplant bags was about 200 mLs, so it's pretty teeny tiny. And then we have to watch you incredibly closely for side effects, which we'll get into. And really that needs to be done in a center that knows how to watch for those side effects and has the drugs to treat them, which we'll get into as well. But that's the process in the patient journey. So outcomes, does it cure cancer? Well, the short answer on that is we don't know. But let's get into how we actually decide to use the CAR Ts. And what we're going to do first, and the way that we think about this, is there's 2 FDA-approved products right now. One is called Abecma, or ide-cel is the nickname that we give it. The other one is called Carvykti, or Cilta-cel. So we're going to talk about the 2 different spaces in which we'll use it, and then the difference between the 2, and then we'll talk about that cure question. So, like we said before, in cancer care, you try the new stuff out on people who've, have really bad myeloma that keeps going and going and going. So these patients had an average of 6 different kinds of treatment for myeloma, and so that's a lot. And what we saw was when we gave them this, we saw an overall response, meaning their myeloma got somewhat better in 81% of patients. So if you think back to that initial curve I showed you with all that kind of time, really impressive that you're going to see these patients who've had that much treatment have responses to something. But what we found is important is that the deeper the response, the better off the patient does and the longer their treatment lasts. So then that's called a complete remission, and we'll talk about that first. So the complete remission rate was about 28%, and if you look at that curve, or those curves on the right, that top curve, the light blue, those are the patients who had complete remissions. The purple line is people who were 90% better than they started, And then the gray line is the one that patients were only about 50% to 90% better. And what you can see is that if you got to a complete remission, this treatment kept your myeloma under control on average for 19 months, compared to if you had a partial remission, it was only about 4.5 months. So that shows you how important it is to get a response. Now, then we said, okay, well, if it works so great for those people who got 6 prior lines, how about people who got 2 to 4 prior lines? And the other interesting thing is we had a lot of patients who were those triple refractories who we didn't expect these people to make it the next 6 months. So we can talk about that. They compared this, and then they said, okay, well, maybe we should give the CAR T, but let's compare that to, some other treatment that we could routinely give at this stage. And when we give you something that we could normally give you, we call that standard of care. So some people got the CAR T, some people got the standard of care. In standard of care, it's what we would expect for this group. The myeloma was back within about 4 months. In the ida-cel group, or the Abecma group, the myeloma stayed away for about 13.3 months. So then we said, okay, it's probably better to use these CAR Ts, earlier than standard of care. We did very similar trials in patients who have gotten Carvykti. So this is called Cartitude. That's cute, right? It's like an attitude, but it's a Cartitude. Same thing as Abecma, average 6 lines of therapy. Now look at this response rate. It's 98%, and you guys can go look at the slides and see the difference. Complete remission rate up to 83%. And so when you look at these patients, their myeloma is staying under control for 35 months. And if we can push it even lower than a complete remission into minimal residual disease, there's no average time that the myeloma comes back once we've looked at these patients at a 3-year follow-up. And, we'll keep looking as the years go on. Now, what's interesting is that this product actually came out of China and was purchased by Johnson & Johnson, or we say J&J. And so we do have longer-term data out of China. And what we're seeing is those survival curves are tending to flatten out at about a 30% response rate, and that's at a 6-year follow-up. So we think CAR T, based on the Chinese data, might, have a potential to cure in about 30% of patients who get it. But really right now we don't know because it just takes more time because myeloma patients, if you look at an average study, we don't have an average amount of time a myeloma patient lives because we can keep giving you new treatment and they keep working better and better. Now, this is to say, should we give myeloma earlier, Carvykti earlier? And so this is where they did that same study as what happened with the Abecma study. And what happened is that these patients only had 1 to 3 prior lines of therapy. The other study was 2 to 4. And the Revlimid or the lenalidomide, you had to be refractory, which means it stopped working for you. It couldn't be that it made you nauseated or it gave you a rash or you stopped it because you had diarrhea. You truly had to be refractory, not intolerant. And only about 15% of patients were triple refractory compared to the 65 in the other study. So they said, okay, well, we're going to give you CAR T, and these other people are going to get, they had a list of regimens that they could get. In the patients who got that standard of care, about 80% of them had relapse within 30 months. The CAR T is the cilta-cel group, is that top line. You can see at the 30-month time period, and this is an early line therapy, there's no average relapse rate at 30 months. So we're almost basically at 3 years, and we don't have an average relapse rate. What you will see is that in the early months, of months 0 to 3, that it looks like the standard of care group did better. It's because we had patients who just didn't behave as well with their myeloma while they were doing bridging, or maybe they, so their myeloma was more aggressive and they had more aggressive myeloma that unfortunately a few patients passed away from their disease. So does CAR T cure cancer? Probably not for the majority of people. I think we're going to look at that long-term data. There might be a percentage of people where it does. What it does do is it gives us long periods of disease control without other treatments. So there's no additional, there's no maintenance, there's no steroids, there's none of that kind of stuff. And we know that the deeper, this is my myeloma iceberg, we know the more that we melt the iceberg down and can even get that iceberg so far down that we can't find the DNA of the myeloma, and that's called being MRD negative, that's where patients survive longer and don't have average relapses. And so we're using this CAR T-cell therapy to look at newly diagnosed patients, and maybe one target's not enough, maybe a CAR T should have two. We have a new product called Anito-cel, which we expect is going to get FDA approval in the next year, which looks to be even more effective. More people become MRD negative faster with that product, is what it looks like so far. Those numbers are smaller, and we're not seeing the side effect profiles. So quality of life. This was a really nice study done by Dr. Cohen at UPenn. And when they looked at patients at a 6-month follow-up, they said 60% of patients had decreased pain, fatigue, GI issues, nerve pain, and that about 71% of patients felt like their expectations were met by CAR T-cell therapy, and 21% said it was better than expected, and 71% of patients said, yeah, this is way better than anything else I've gone through. And we can look at this too. There's other data about, improved physical functioning, activities of daily life. So that would be like showering yourself, toileting yourself, getting food prepped for yourself, emotionally feeling better, better relationships and social functioning. So ultimately, patients really felt like they had better quality of life. So what's the flip side of that? The flip side of this is toxicities. And so we want to think about this a couple different ways. As you know, treatment itself is going to have toxicities. So if you think about that lymphodepleting chemo, that can make you nauseated. That is going to lower your blood counts. It's not going to make you lose your hair, and it's not as intense as the chemo with a stem cell transplant, but it's chemo. And when it lowers your blood counts, it's going to put you at risk for needing blood transfusions. And also risk for infections. We have a lot of antibiotics that we use, and we look for infections. Lowering blood counts is what cytopenias are called, and so you could need transfusions. But the things that are specific to T cells are what we call cytokine release syndrome, or CRS, and then another thing called neurotoxicity. And we're learning that there's all different kinds of neurotoxicity. One of them is ICANS, which is something that happens really early in CAR Ts within like the first week. And then there are later neurotoxicities. And depending on the product you get, we know we can typically anticipate when do we think this is going to happen and how long is it going to last. And so that's something that as you're talking to your doctor, they can walk through with you on the timeline. What that means, though, is that if you're doing an outpatient CAR T, in my program, we need to see you every single day for 14 days straight, because that's going to be the biggest risk period of somebody having a side effect. So we talked about these side effects, low blood count, infections. There's a really weird reaction that we'll talk about called HLH, easier way than saying hemophagocytic lymphohistiocytosis, low antibody levels, that late neurotoxicity, and even other kinds of cancers. So low blood counts, we recommend that for 3 to 6 months after the CAR T, when you go back to your routine oncologist, if you go back to a different doctor, that they monitor those blood counts carefully. If we don't see the blood counts coming up, we might need to do a bone marrow biopsy, and sometimes we just need to boost your immune system. And if you have frozen stem cells stored, that's something that we can do. We can just run those in like a little blood transfusion, and they'll go back there and grow up your immune system. Infections we talked a lot about. It's because we lower immune cells, and so just like with stem cell transplants and other therapies, we put you on medicines to help prevent infection, and if you have a fever, we got to look for an infection. Now, when we are knocking out all the plasma cells, you're not going to be able to make good antibody levels. And these CAR Ts last in your body for about 6 months before they die. So if you think about that, you're not making antibody for the first 6 months, then you're waiting for your plasma cells, the healthy ones, to grow back, and that takes another 6 months. So really, we see people need antibody infused, called IVIG, for about a year. So that's another one that we like to look at to help prevent infection. This HLH, I think what I want you guys to know is this is incredibly severe inflammation. The body gets really sick. liver gets really, really severely inflamed, high fevers, big issues with bleeding. It's incredibly rare, and basically the CAR T doctor needs to be involved immediately. If it happens, it's typically going to happen while you're still with your CAR T doctor. And then late neurotoxicities. What this means is within the first week or two, we worry about any kind of confusion. Are the T cells, causing any kind of issues where you can't think straight and they're causing inflammation in the brain? When they do that, we can treat you with steroids and make the cells calm down. But later on, we're looking for weird stuff, like is it making your nerves jittery and a tremor? Are you acting like you have Parkinson's disease? Do you have a facial droop, like it looks like you had a stroke? And those things are incredibly rare, less than 10%, but we do know that when your myeloma is not coming or not in control coming into a CAR T, that's where we see bigger issues. Now, one of the other things, I'm going to go back a couple of slides here, is something called cytokine release syndrome. So when these cells are releasing all their inflammatory proteins, those are called cytokines, and then those cytokines are then the things that make you have high fever and can make your lungs kind of soupy so that you have a need for oxygen or drop your blood pressure. And that can be treated also by calming down the T cells, and that can happen with steroids, or it can happen with a specialized medicine that blocks the inflammatory proteins. And typically the only hospitals or clinics that stock those kind of medications are hospitals that do CAR T cell therapy. So, for example, standard practice in most CAR T centers is that you have to live, and this is what the package insert says as well, you have to live or stay within 60 minutes of your CAR T cell center for the first 30 days. And that's so that we can get you access to these special medications quickly, because it's easier to shut down this inflammatory syndrome when it's happening early versus when it happens late. The other thing, because of the neuro side effects, that's important is that the package insert also says that you cannot drive for 2 months or 60 days. So that's something also to really keep in mind. So who's a candidate for CAR T? Well, first of all, you do have to have relapsed myeloma. So you can't get diagnosed with myeloma and get a CAR T. You have to go through one kind of therapy first, and you have to be refractory to Revlimid is the current indication. Or you could have 2 previous treatments, but you have to have had the 3 different types of drugs, the CD38 antibody, the IMiD, and the PI. You have to be healthy, good lungs, good kidney, good hearts. You have to be able to take care of yourself and be pretty functional, and have a caregiver who's going to keep an eye on you for 30 days. And it doesn't have to be the same person all the time, but you can imagine that if you're confused, you're not going to call and let us know and get yourself to us to take care of you. We need a caregiver to be our eyes and ears. And one of, I think, the most important things is that your next best treatment is always available to you on a clinical trial. So I know we have a lot of really good questions, and I feel like I raced through that a little bit, but I just really wanted to give time to those questions. I think the final thoughts about CAR T cell therapy, and this is a cool picture of these blue T cells are in there just eating away at the cancer cell, which is the purple stuff. When we use CAR T cell therapy early in treatment, we get deeper and longer responses. We are now really just starting to understand which patients are going to have side effects and what problems they're going to have, and how can we head those off at the pass. So I mean, really just within the last 6 months, we're starting to see how can we prevent this from happening instead of letting it happen and then treat it when it does. And then, not everybody can collect a healthy T cell. If you've been through a lot of treatment, sometimes your T cells are just kind of weak. And they're just kind of floppy. And so can we get T cells from other people and do what we call off-the-shelf products? And then should we combine these different treatments to look at different types of CARs, like that Anita cell product that's coming out, is going to be pretty cool. So with that, I will let Michelle help us go through some questions, and I appreciate everybody's attention.
Thank you, Dr. Gregory. That was an excellent presentation. For our audience, if you have questions for Dr. Gregory, please use the chat box on the left side of the screen to submit your questions. We will answer as many questions as possible in this time. And boy, are there some great questions. Let's go ahead and get started. For patients who work a flexible remote job, do you recommend that they take a leave during CAR T-cell therapy or continue working? And if you recommend that they take time off, how long?
That is a really great functional question about being a person that needs to work, so I appreciate that. I do recommend that people take time off. I recommend that you give yourself the 2 months. I figure if you can't drive for 2 months, you probably shouldn't be working for 2 months. That being said, I have plenty of patients who have sailed through CAR T and have had no issues, and they just look at me when they're coming to the office every day for the 14 days, and they're like, why am I here? So, for my patients who do work, what I've said is that if you want to continue to work, that's fine, but I need your job to know that at any moment, this could be like you were there one day and fine and operating just fine, and then the next day something happened suddenly and you couldn't log in and it's not going to get done. So if they are dependent on you to be doing payroll or whatever, log into these meetings, and they can't take that over at a moment's notice, then you really shouldn't be working. But I would say most patients feel like they can go back to work at the 60-day mark. So that's an awesome question.
Agreed. The next question, how does each center select which CAR T they will use? Is it patient-based or what the center is approved to deliver?
That's a great question. So there are 2 CAR Ts like we talked about, Abecma or ide-cel, and then Carvykti cilta-cel that we covered. In our center, we only carry cilta-cel because we think that the data supports that that's a better CAR T. It lasts longer, and that's my personal opinion. Just to throw that out there. And so I don't really want to be giving a product that's on average only I don't want to put people through that for 5 months of disease control. Now, I will say that Abecma has a lower side effect profile than Carvykti. So some centers feel like, well, if I have a patient who's not as healthy, but I want them to be able to get a CAR T, I'm going to go ahead and I will give them Abecma, but then I'll save the cilta-cel for people who are robust and don't have, big other health issues. You do have to be opened as a center to deliver CAR T by the company and by insurance plans, so that does play into it. So, yeah, great question about how we pick.
Are there any complications if you've been heavily pretreated, especially with Revlimid going into CAR T-cell therapy?
That is a great question. So, first of all, there's 2 big pieces that we think about here. The first off is that when you make a CAR T and you're collecting a T cell, think about this. It's garbage in, garbage out, right? So if you have a T cell that's been through tons and tons and tons of different treatments and you're weak and floppy, and then you can't make a CAR T cell that's really going to go out there and pound on things like Captain Marvel, then, that does really influence how robust the CAR T is going to work. Now, with lots and lots of Revlimid under our belt, part of what Revlimid does is it doesn't drag the T cells down. It actually kind of pumps them up. It revs them up. And so that one we don't worry about as much. What we do worry about more so are patients who've had a lot of traditional chemotherapy. So maybe they had 2 transplants, and then to get their disease under control, drugs weren't working. So then they had to go back and do those good old-fashioned chemotherapy cocktails. The other thing about people who have been heavily pretreated and had a lot of treatment is that their bone marrow gets weak, and then we're going to hit you with this other chemotherapy, the lymphodepleting that we talked about, and the T cells, which can drive down blood counts. And so it can be really hard on your blood counts, the healthy cells like platelets and red blood cells and other immune systems to recover after the CAR T and have low blood counts. So we do have a system where we look at your risk for that. It's called a CAR hematotox score. So that would say, okay, well, we're pretty sure you're going to need a stem cell boost after if we have them in the freezer. Or we say, you don't have any stem cells, and chances are is that I'm going to turn you into somebody who needs platelet transfusions for the rest of your life. So maybe this isn't a great idea.
Great question, great answer. Do you recommend similar vaccination guidelines as those followed after a stem cell transplant, or are there different ones that you recommend after CAR T therapy?
Oh my gosh, vaccinations. We're all trying to figure out what to do with vaccinations, right? So great question. We definitely think that patients likely need to be vaccinated after CAR T. But we don't currently have any standard guidelines through our national and international organizations on what those are or what schedule that should be on. A lot of centers have basically said that at a year, we think you probably should do the same vaccination schedule as after an auto stem cell transplant. So that's going to include polio, Haemophilus influenza B, DTaP, hepatitis B, hepatitis A, pneumococcus. I'm missing someone. Flu, COVID, those kind of vaccines. And then one of the things that we do know in CAR T patients is that we have to get your healthy T cells back to get you to respond to a vaccine. So that's called a CD4 count. And we know that that needs to be over 200. So that's really important, and we think it's probably okay to get your MMR vaccine, because I think everybody's pretty worried about measles right now, when your CD4 count is over 200, and that we can do that a little bit earlier than the 2 years that we typically waited.
Can I have a second CAR T treatment if the first one doesn't work?
That is a great question, too. So I'm going to branch out on this and add sequencing into here a little bit also. So we've done a couple different things with CAR T. So we have patients who are on clinical trials who have gotten the anti-BCMA CAR T. And you have the patients where it just doesn't work right off the bat. And typically, we don't have extra cells made and ready to go in that situation. And your healthy T cells, we can't collect anymore to make a new CAR T, so that ends up being a problem. We do have patients who their myeloma came back pretty fast within the first year or so of CAR T cell therapy, and maybe the study, because these are all patients who are on clinical trials, they could give them extra CAR Ts, and they maybe had about a 50% chance at responding, and it didn't last very long, only a couple months. And they did the same thing for people who relapsed, a couple years later. And same thing, it just doesn't work as well. What does look like it works in research is if you flip the target. So we talked about that BCMA target, but there are new ones. And they're combinations. So there's a product out there that's a combination of one receptor called CD19 and BCMA. That one looks pretty awesome. So we're responding to that one. Another one is a target called GPRC5D that looks like you can respond to that CAR T later. That one is having some really weird neurological problems that we're trying to shake out. And then there's one that's a combination of GPRC5D and BCMA. So the answer is yes, you can. Chances are you'll collect T cells better if it's been, well over a year since your first CAR T, but we do need to change the target. To take that a step further, sometimes when patients come to meet me, they're like, well, why do I have to do the CAR T cell? That kind of scares me. It's kind of crazy. Could I do one of these Wonder Woman drugs, these bispecific antibodies first? And the problem with that is that if you give somebody a bispecific antibody such as elranatamab or teclistamab, are two that are anti-BCMA, you burn up that receptor. So then when you try and use the CAR T after to the same thing, the CAR T doesn't have anything left to go after, and so it doesn't tend to work. The flip side of that that's weird, is that if you do the CAR T first, and then it stops working, you can come back around later when the patient relapses with the Wonder Woman drug, the elranatamab or the teclistamab, and you still see pretty equal response rates compared to the patients who've never had what we call an anti-BCMA therapy before. So I really encourage patients, if you think you want to ever have a CAR T, do not go get the bispecific antibody to the same target first.
If a person is taking medication to keep depression and anxiety under control, Will that affect the risk for CAR T cell side effects?
That's a great question. So currently with depression, anxiety, no, we don't see side effects with those kind of medications. We do, it's hard to go through treatment. And so in a lot of CAR T centers, we make sure that we have really robust social work and psychology teams to make sure that we're checking in with you and feel like you're supported and getting through treatment well. But medically, not an issue. Where we worry is if somebody needs a blood thinner to prevent a blood clot and we lower your platelets, that can be kind of tricky. We worry about patients who have had heart surgeries and need to be on special blood thinners all the time. Some of the newer heart surgeries are a lot better, so we don't run into that issue as much. And those are some of the bigger issues where we worry with medication.
Thanks. How long do you have to be on IVIG infusions after CAR T cell therapy?
Good question. So IVIG, you can expect to be on it for at least a year before your immune system makes healthy antibody, and a lot of patients have to be on it for at least 18 months after CAR T cell therapy.
Are there studies looking at sequential CAR T and repeat stem cell in either order, or if so, what interval?
Good question. Okay, so there's lots of studies with lots of pieces to this. There are studies where patients got a stem cell transplant first, which was planned, when they first got diagnosed, and then they got the CAR T second, right after, recovered, so basically like 8 weeks after their transplant, and then went on to the CAR T. Some of those studies have been closed because it just didn't look like it was really effective, and it makes me wonder if the CAR T cell needs to see at least some myeloma so that it can act against something, but it's kind of a double-edged sword. You don't want to give it too much so that it gets super aggressive and causes bad CRS. Then out of China, they're doing a lot of good sequential CAR Ts where they give you a CAR T to one target, and then a couple weeks later they give you a second target CAR T. That has kind of fallen by the wayside in the United States because the technology is evolving so rapidly that we can make a CAR that will hit two at the same time, two targets, so we call those dual CARs. So we're doing more studies with the dual CARs. I would say, however, that second transplants have largely been replaced by CAR T. So it's pretty rare to see a patient get a second transplant these days.
That's so fascinating, so exciting too. Do you see greater cytokine release syndrome and neurotox issues with people who have autoimmune diseases like rheumatoid?
That is such a great question. No, because what happens is when you get that fludarabine and Cytoxan first, it knocks down your immune system. And then your regular immune system that caused your autoimmune issues sorry, we have a helicopter landing, so I know that got a little loud. So we see less autoimmune stuff while you're going through this, and because it makes your T cells stay away for the first 6 months, and those CARs are active, and the CARs, just to think about one thing, I am here to fight BCMA, like this is what I do, I am on target, I am on message, I do not have blinders on, I am not distracted. So then in that way, they're staying away from your autoimmune issues as well, because they're just so focused on the myeloma cell and not those other tissues like the synovial tissue in your joints. Then it takes another 6 months after that, once the CARs die out, for your T cells to grow back. So actually, I think people with autoimmune disease actually feel really good, and they feel like they get a hiatus from their autoimmune disease. Great question.
Agreed. Is there something called CAR T brain? Is it different than chemo brain?
CAR T brain, I think what I would probably label CAR T brain as, so I do think that there's the effect of you go through more and more treatments and you definitely get chemo brain. So I think that that's part of it. I think what we worry about longer term is if those CAR Ts are in the spinal fluid and they're in the brain and they're working on the brain, then yes, we would call that late neurotoxicity. Now, I don't think that that's something like, God, I can't find my car keys, or where are my glasses? Oh, they're on top of my head, or where's my phone? It's in my hand. Or somebody told me their name and now I can't remember it. I mean, these would be, if it's CAR T related to a T cell being active, this is profound. This is, I ask you what the year is, and people tell me like 1944, and I'm like, oh, no. Or, who's the president, Jimmy Carter? Like, we are really, really firing pretty low. And that's, I would say that's pretty obvious to your family, and that's typically when people would let us know that there's a problem. Now, I tend to see something that severe within the first couple weeks of CAR T, and so you're getting screened every day, and you have to do these, what's called your ICANS assessment, where you have to sign your name and tell us how to count backwards, and do you know what this thing is? Yes, I do. It's your phone. It's a pen. So we're screening for any kind of subtle differences as well.
My daughter had a CAR T for multiple myeloma and has had Parkinson-like symptoms for a year. Are you familiar with this? Is there a chance she'll recover?
I'm sorry to hear that. That's incredibly rare, and that's really, really tough. We don't know if people will recover. That can happen at any stage, which is frustrating with CAR T. We tend to see it more with the cilta-cel product. We don't see it as much with ide-cel, and we're not seeing it with anito-cel yet, but it's early days with anito-cel in terms of that research. We've tried a lot of things for patients here at CBCI that haven't been particularly helpful. We know that we've learned we should not over immunosuppress patients. One of the things that we try and do now is, can we just shut down the CARs completely? Because usually that's the problem. Are there active CARs in the spinal fluid causing this issue? And so that's typically what has to be assessed. And then if we say, okay, yes, it does look like the CARs are still sticking around long term, then we need to kill them. And the way that we kill them is with high-dose chemotherapy called Cytoxan. And then we have to be able to have stem cells available in the freezer to recover the bone marrow after that. So right now, as a myeloma community, we realize suppressing the immune system forever, not good, doesn't work. And maybe we need to be shutting down the CARs. So that's where we are right now in understanding. And then we do use a lot of the Parkinsonian meds. But I have to say at this point, we don't know how to make Parkinsonism go away.
Are there tests to find out how many T cells remain 1 year post CAR T therapy?
There is not a commercial commercial assay or test that we can do to look at specific CAR Ts. There's a couple tricks that we have up our sleeve. We can actually do some HIV testing because this virus, is built off an HIV backbone. Sometimes you can get those tests to be positive, and so you can find them that way. The other way is that our pathologists here at CBCI are pretty awesome, and they've come up with some testing on T cells that they think they can tell the difference between a normal T cell and a CAR T cell. But unfortunately, there's no, I can't send a blood sample back to the company and say, how many T cells do we have in here? We're hoping in the future that'll be something that's readily available to all of us.
Okay, well, this will have to be our last question. We're starting to run out of time. Is there a certain diet that one needs to follow after CAR T?
I think in general, the anti-cancer best diet, for just being on this earth is nothing any of us want to do because it's way more fun to eat French fries and hamburgers and that kind of stuff. We think the closest thing is a Mediterranean diet. What we really want to do is increase our gut microbiome and provide our bodies with enough protein to grow good, healthy cells. So we're learning more about the bacteria that live in our intestine and how that interplays with our immune system. And there are some studies that have shown that when you have a healthier gut biome, that you actually have better immune function and that the T cells regulate themselves better. So the closest diet we can get to is the Mediterranean diet. And the key there is lots of lean protein rotating your proteins, and sometimes protein doesn't have to come from like a dead living being, and it can be, well, I guess a bean is dead too, but a dead animal. And so, if one day it's you get all your protein through beans, and then you're going to do like a lean pork, and you're going to do a lean red meat, and it should not be red meat every night, all night, or all week. We want a lot of complex grains in your diet, so not white bread, go with wheat bread or nut and seed bread, and lots of healthy fruits and vegetables. Probably half the plate should be fresh fruits and vegetables. Everything that you love can be in moderation, because you are trying to live for some quality of life. So if you want to have some wine there, dessert, that's definitely great, and whatever makes you happy, because where you are mentally is also equally important.
I love that, Dr. Gregory. On behalf of the BMT InfoNet and our partners, I'd like to thank Dr. Tara Gregory for an extremely informative presentation. And thank you to our audience. You have sent us some wonderful questions, really, really astute questions. Please contact BMT InfoNet if we can help you in any way.